Bismillahirrahmanirrahim. Assalamu alaikum. Every day we diagnose diabetes, hypertension, obesity, polycystic ovarian syndrome, MASLD, and depression. But what if we told our patients they are all branches of the same tree? What if the crisis we face today is not a collection of diseases, but a collapse of human metabolism? I am Professor Dr. Javed Iqbal FAROOQI, and you are watching my YouTube channel, Medicine Made Easy. After decades of clinical experience, I believe it's time we as physicians challenge the outdated model of disease management and look deeper into the root metabolic dysfunction silently affecting millions of people. Are we treating numbers? Are restoring health? Are we managing symptoms? Are reversing disease? This is not just another lecture. It's a call for a paradigm shift from reactive medicine to proactive metabolic care. Let's explore the science, the blind spots, and the way forward. The metabolic crisis, why it's time for a paradigm shift. A 42-year-old patient consults a busy internist with a packed schedule, BMI of 29, fasting glucose 99, triglyceride at 180, and ALT slightly elevated. He has been feeling sluggish, but everything looks almost normal. The physician reassures him, advises to exercise, and come for follow-up visit after 6 months. 6 months later, the patient comes back 5 kgs heavier, HbA1c at 5.9, and his fatigue is worse. Fast forward 5 years, and now he has type 2 diabetes, fatty liver, and hypertension. Sounds familiar? Yes. We see this play out every day in primary care, GI, and endocrine clinics. But what if we could stop it before it starts? The problem, metabolic dysfunction, is everywhere. 9 out of 10 adults have some degree of metabolic dysfunction. Insulin resistance, fatty liver, and prediabetes are often ignored because they don't fit clear-cut disease criteria. We are trained to treat diseases, not to optimize metabolic health, and that's a problem. So question for you is, what's the most common early metabolic warning sign you see in your practice that often gets overlooked? Drop it in the comment sections below, and we shall proceed with your input. The root of the crisis, what's that? Why the current model fails? Reason is the reactive approach does not work. We wait for HbA1c to hit 6.5 before calling it diabetes. We wait for fatty liver to progress to cirrhosis before taking action. We wait until patients have hypertension, obesity, and lipid issues before treating metabolic syndrome. But by the time these conditions show up, the damage is already done. We are focused on the wrong metrics. A normal fasting glucose does not mean normal insulin sensitivity. A normal BMI does not mean someone is metabolically healthy. A normal ALT does not mean the liver is not in trouble. Instead, we should be asking, how is their insulin resistance? What's happening in their gut-liver axis? And how can we intervene before full-blown disease develops? So the paradigm shift from disease management to metabolic optimization is required. Instead of waiting for disease, we need to measure and manage metabolic health proactively. So the first component is rethinking the diagnosis. Catch it early. Check fasting insulin, insulin resistance, triglyceride glucose index, and ALT trends, not just fasting glucose and HbA1c. Fatty liver is not just fatty liver. It's a metabolic red flag for future cardiovascular risk. Clinical case challenge. A 38-year-old with BMI of 27 has ALT at 42, fasting insulin of 15, and triglyceride at 190. His glucose is normal. Would you intervene now or wait? Drop your answers in the comments. The second component is the expanding treatment beyond glucose control. And this should be the component of the new paradigm. GLP-1s are not just for diabetes. They impact metabolic health, weight, and even cardiovascular function. The gut microbiome influences metabolic disease, but how often do we consider it in treatment? This is the question. Lifestyle interventions must be prescribed like medications, personalized, measurable, and monitored. Just a poll. What's your go-to first-line intervention for early metabolic dysfunction? A, lifestyle changes. B, metformin. C. GLP-1. 4. Others. Third component of the new paradigm should be thinking beyond weight loss. Metabolically healthy obesity exists, but it's rare. Metabolically unhealthy normal weight individuals exist, and they are missed. Both composition matters more than BMI. The body composition matters more than BMI. Would you treat a normal weight patient with signs of insulin resistance the same way you would treat an overweight patient? Let's discuss. So the takeaways, practical steps for clinicians: stop waiting for disease, treat metabolic dysfunction early. Use better markers, fasting insulin, HOMA insulin resistance, and liver function trends. Look beyond glucose, gut health, lipid patterns, and early NAFL or MASLD matter. Rethink treatment, lifestyle, pharmacology, and gut metabolism interplay. Let's continue the conversation. Please share your comments below. What's the biggest metabolic challenge you face in your practice? And on the basis of this, we will continue our discussion in the next episode. Coming up next is the insulin resistance, the silent driver of chronic disease. So subscribe and turn on notifications. Let's define metabolic medicine together. Thank you very much for being with me in the second episode. In the next episode, we shall discuss insulin resistance, the silent driver of chronic disease. Thank you and see you in the next episode.